to start our
So, Dr. Shashank, Dr. Abhishek has joined. Dr.
Hello.
Abhishek. Huh.
Yeah, Dr. Shalini, hello. And I'm thankful to Dr. Shalini, who is regularly hosting this type of meeting, which is very interesting. This is the second monthly meeting of our session, and we are very delighted to have the cataract session with almost very great surgeons, Dr. Prakash Gupta, Dr. Chitra Ramamurthy, Dr. Charu Mittal, Dr. Gaurav, Dr. Manish, and Dr. Shakya, all with us for this wonderful meeting. So this is a different type of meeting in which we have got 3, 4, 5 presentations with the 3 minutes video presentations followed by discussion, and I'm very hopeful that this would be very well taken up by all the UP members and all AIUS members as well. So with these words, I invite Dr. Is Dr. Shashank here, our president?
I suppose
Shashank sir is here.
missing.
If he is not here, yeah. So if he's not here, I would invite ask Dr. Shalini to continue with this meeting. Thank you so much.
Thank you so much, Dr. Abhishek, and good evening, everyone. So today we are having a different kind of program where there will be 5 video presentation from stalwarts of ophthalmology. Dr. Chitra Ramamurthy madam is with us, Dr. Prakash Gupta, Dr. Gaurav Mishra, Dr. Manish Mahindra, and Dr. Rakesh Akya. They all are experts in their field, and you will be seeing very innovative videos from all of them. And first, we will be showcasing the video, followed by discussion of approximately 6 to 7 minutes. Whatever queries you have, you can put it in chat box, and from there we will take up the query, and accordingly the experts will answer your questions. So, without wasting much time, I would request Dr. Pranav Saluja, who is upcoming surgeon from Prayagraj, to moderate the session. Dr. Pranav.
Thank you so much, ma'am. To start with the webinar series, it is mainly about surgical challenges which are faced. And the first lecture is by Dr. Chitra Ramamurthy. We also have an expert panel which consists of Dr. Vinita Singh, Dr. Charu Mittal ma'am from Meerut, Professor Adib Alam Khan from Aligarh, JMC, and Dr. Anand Sharma from Varanasi, and Dr. Lakshmi Singh from Lucknow. So I would request Dr. Chitra Ramamurthy to start with the presentation. Chitra Ramamurthy ma'am is the medical director at Eye Foundation, Coimbatore. She is the chairperson of ARC at this moment, and she is also standing for vice president in AIOS. So she'll be talking about it's a tough nut to crack, PPC cataract, which is posterior polar cataract. So over to you, ma'am.
Very good evening to one and all of you, and thanks so much, all the stalwarts of UPSOS, for inviting me for your UPSOS webinar. I still am fresh with the wonderful weekend spent at Gorakhpur with many of you. So without ado, I'll go on to my talk. I think every polar cataract comes with its own quantum of challenge. It could end up as a straightforward case, but then we pursue all the steps of the surgery as if there is a challenge therein. This was a polar cataract of a soft cataract, but visually it was bothersome for the patient. He had barely a vision of 660, was not feeling very happy with it. So the important thing was the pre-op ASOCT told me that the posterior capsule was discontinuous with the contents in the patellar fossa. So without a single thought, I decided that I have to start the surgery thinking clearly, knowing that I'm operating in an open posterior capsule. So I make a small rhexis, which is most important because it might become the future's platform for a 3-piece IOL to be placed, maybe with an optic capture if I'm able to do it. But I decided not to do a hydrodelineation or a hydrodissection, but just a mechanical delamination so that There's no unnecessary gush of fluid going behind. And we knew this was a very soft cataract, and just disrupting the superficial cortex and epinucleus itself would loosen those links within. And I thought that should be sufficient. And I start with my IA, and you start eating up the epinucleus and the soft cortex. And you can see clearly there is that central small opening. But the ease with which I'm able to tease out the cortex tells its own story, that there is no vitreous in the capsular bag or in AC, because I would not have been able to pull on the cortex with such ease, and there's no distortion of that PC opening. It continues to remain the same. If vitreous was present, I could not have so easily evacuated the capsular bag of the cortical remnants. So I ensure that the anterior chamber is stable, and the IA infusion is not directed towards the PC opening, but towards the back of the cornea. And by doing a bimanual IA, I'm able to exchange hands and ensure that I reach out to the subincisional cortex. Then I inject 1:10 dilution tricot, so that I want to know whether there's any aberrant vitreous there. And then I do a shallow anterior vitrectomy. Or as it is, you can see that there's hardly any evidence of vitreous, but I was not going to be taking any chances to have a vitreous seen the next morning and a week of it at the incision or the side port. So I do a shallow vitrectomy. But the next thing which I do, which I'm able to do in this particular case, I'm not sure this can be repeatably done in all PPC cases, but I do a posterior capsulorhexis here, 3.5 to 4 millimeters, and I use both the right and the left. And with the micro forceps, I ensure that I manage to get a rhexis. Now, till it is done, I'm never too sure. But the plan of action, I was very ambitious that I was going to plan this premium IOL with a toric correction incorporated. And in this capsular bag, with the PCC done, even the manuals of injecting an IOL itself can rip the posterior capsule in a posterior polar cataract. But having made a PCC that ensured that the posterior capsule was continued to stay the way it was, very carefully I hydrated the wound, because even hydration of wound can cause enough disturbance. But a PCC is a major advantage here, because otherwise the rip in a posterior capsule is always goes horizontally across in a polar cataract, and you can just never place a premium IOL and a toric IOL and a single piece IOL in a capsular bag in these situations. And I did tell my patient that it may happen, may not happen, but you can see with the Varion overlay, it's right bang on the axis, 77 degrees, and the side cyclotorsion tracker also shows that the cyclotorsion compensation is done, and the case is complete. Thank you very much.
Very beautifully managed, ma'am. The best point was the centration of the lens, and going for the toric lens would have been really difficult, but you managed it so beautifully. So I would request Dr. Vinita Singh, ma'am, to comment on the video.
I was actually watching the video with particularly when she was clearing up the posterior capsular opacification, because that is the time and that is the point when we have to be very careful. And she beautifully managed it. And one very good point that she has said, that in these patients we should start with a smaller capsulorhexis, because at the end of the case that might be the providing us the support for the implant. Very well demonstrated and a very lovely video. Thank you.
Thank you. Thank you so much.
Thank you so much for your comments, ma'am. Dr. Charu Mittal, ma'am. Any expert?
Beautiful video, ma'am. Ma'am, my only one point here to ask you would be that the posterior gap that was there when you removed the cataract was also quite continuous and curvilinear. So would you always do a PCC, or if we see there is no rip or nothing, it's stable, we can just go ahead and place the IOL?
Yeah, that's a very, very valid thing. It was a continuous, apparently continuous looking in a small in size. I could have gone straight and placed the IOL in the back, but the only thought was that these all these polar cataracts, they are so insidious and so unsure you are. We don't know when this small opening can just rip. So I thought, why not further scaffold it by making it a proper PCC and then do it. Now I could have easily managed. In fact, sometimes even with a little larger rip also, which cannot be converted into a PCC, you may be lucky to place a single piece IOL in the bag if there's fair amount of support. And but this was just one case where I could do it well, and these are situations which we can do as and when we come across. But then I think every step in a polar cataract is, if the PC is open, you're definitely not sure. So the most important message for all of us in a posterior polar cataract is to incorporate a pre-op anterior segment OCT in all our cases. We did a study of some 77 eyes of polar cataract, wherein what we did was we did an ASOCT, and wherever the posterior capsule was continuous, and in those cases, we actually did a gentle hydrodissection and a hydrodelineation. And we did it as a routine case, but ensured that the parameters were normal, ensured that each time was removed, the AC was continuously formed. There was no shallowing of the AC. So in those cases, nowadays in ASOCT, the PC is intact. We do a regular, careful phacoemulsification. And if there is a discontinuity in the PC, or like this, wherein I should have shown the ASOCT picture, but I was so worried about the time I didn't show. If that lens matter is apparently going into the patellar fossa, where it's a clear-cut PC opening, then those situations, we would have to do all the steps of a polar cataract.
Thank you, ma'am.
Yes.
Thank you so much.
Yes, Dr. Abhishek?
Yes, madam, one question. In this condition where the vitreous was not coming, could you have placed the IOL and then did a vitrectomy if required?
I did inject tricot there, and all of us saw that there wasn't that staining of vitreous was not there. As I was planning to do a PCC, I had planned beforehand, because I was going to place a premium IOL, and it was patient's expectations were so high in spite of the counseling. I decided that I was not going to not address the little bit, and it was a very shallow vitrectomy which I did. I didn't go deep in and all that. So, but yes, we could have got away. See, after injecting the IOL, with the impact of the IOL in the capsular bag, there is some vitreous disturbance which gets created. Then you have to go behind to remove the vitreous, and in the process, you might actually open up the posterior capsule. See, this is not a regular posterior capsule. It is actually an inherent weak posterior capsule. So it seemed to make sense. Go ahead, do a small vitrectomy. Go ahead and do a PCC and then place the IOL. So that I was leaving nothing to chance.
Okay. And one more question. Do you have to choose the IOL in such case? The PC red, although the lens is in the back, but there is slight here position of the lens in such case.
No, we would not do anything, a change in the IOL power if the lens is to be kept in the capsular bag, or even if there's going to be an optic capture. If, of course, a toric IOL should not have been placed, because you have to place the 3-piece IOL in the fulcrus. And but IOL power will change only if there is no optic capture and a 3-piece IOL is in the sulcus.
Okay.
Ma'am, one question. First of all, congratulations for a wonderful video. I noticed that you didn't do any hydro procedure, not even hydrodelineation. Now, suppose you are dealing with a case of nuclear sclerosis grade 2 plus or 3. So, how would you do in such cases with polar cataract?
With an open PC, you mean?
Yes.
Yeah, if it were an open PC, in those cases, I would have to do I would have done a hydrodelineation. I would have done a hydrodelineation. I would have been conscious that I might be forced to convert into an SICS at any point of time, or there might be a nucleus drop. So I would have done a very careful surgery. Or there is one other thing I have done in another case. What I did was, you can't rotate the nucleus also. So what I do is, I do a 4-quadrant, but without rotating. One rough right from proximal to the distal rexus, and keeping my phaco probe horizontally, I made two trenches. And then I split it into four pieces and take it out. So that's one other thing which we could try. In that way, we have four small pieces and they come out.
That was really a wonderful presentation, madam.
Madam, I have a question.
Congratulations. And so I just wanted to know your thoughts about putting three-piece IOL and single-piece IOL in sulcus. And secondly, what are the lenses which you would totally avoid in such patients?
See, in the most ideal case scenario, it should be only three-piece IOL in the sulcus, not a single piece IOL in the sulcus. If you are in one of those very rare moments wherein you have a toric kind of premium IOL, and if you have placed, it should be probably could be a higher myope maybe, where the AC is deep. And in that situation, maybe you could, because I have got away in a situation or two, but these are not to be said in even a webinar. It could be sent one person to the other, wherein you could place in a deeper AC, and whether then you could place it in the sulcus and you can do an optic capture. I wouldn't say that the single piece optic capture is impossible. It can be done. And these IOLs, I've looked at these IOLs after 3 months, 6 months. I've checked even the alignment of the torus IOL continues to remain the same. In those cases, you should put them on knee pain, on non-steroidal anti-inflammatory drops for at least beyond 6 weeks, at least for at least a month.
Okay.
And yes, but you should never even try that even in an extreme scenario in a small eye where there's going to be a crowding of the angle.
I have a question, ma'am, please.
Yeah.
Very true. Right, ma'am.
Hello, ma'am.
Yes.
Ma'am. Ma'am,
Hello.
very actually well managed
Yes,
case. Ma'am, I want to just ask, as you mentioned, during the hard cataract, when you hard cataract with positive polar, if you actually do the hydrodissection first, it always can cause the PC rent. But before the hydrodissection, you make a trench first, and then I did the one thing more. I sometime make a two ports, like, and then make a one trench and another ports with the another trench. So we make a cruciate and then crack it, and then
that's
the
what
chances of PC slightly more, slightly less actually.
no. That's what I said. Like a 4 quadrant. What you're saying and
Yeah.
I'm saying is the same thing. Without rotating the nucleus, you make it as 4 quadrants. And but I don't know whether we mean what. But what I would say is to do all those tricks, to do a hydro dissection, it should be an intact posterior capsule on ASOCT. Otherwise, I don't think we should do hydro dissection in a polar cataract at all. And this particular case I showed had a PC opening. In the pre-op itself, I knew that the PC was open. So actually, it is advised that we do ASOCT even for not just polar cataracts, post-vitrectomized eyes and intravitreal injections. So many patients come from different places having had intravitreal injections done. And there is a likelihood of a PC touch. How many surgeons write in the notes, PC touch? So sometimes patients don't tell they've had an intravitreal injection. So I would treat all of those cases like a polar cataract and do a very careful surgery, follow all these dictums. If we at least know they have had a past planar vitrectomy or intravitreal injections.
Also, ma'am, for a harder nucleus with PPC, would you suggest keeping a bigger CCC in a
Yes, definitely the CC
case of posterior polar
should be bigger than the PCC I made. You would need to have a 5 millimeter oh, you mean PCC or anterior capsular excess?
No,
Your anterior capsular excess should be a little bigger. It should be a little bigger for when you have a hard cataract, but it should not become 6 millimeters. Then you can't, you would or should always try to do an optic capsule with these IOLs. So the excess should be 5.5 at least.
Hello.
Yes. Yes.
Hello, Dr. Adib here.
Yes,
ma'am.
Yes, doctor.
Am I audible?
Yes, doctor. Yes, doctor.
Yes, yes, Dr. Chitramurti. You had a very good presentation.
Thank you.
My only question is, what was the age of the patient?
The patient was 40s, late 40s.
Usually, polar cataracts are a complicated cataract.
Yeah.
So you do primarily in each and every case of polar cataract capsulorhexis, or because of premium IOL you plant capsulorhexis over here?
You mean posterior capsulorhexis? You mean or anterior
Yes.
posterior
Posterior capsule.
capsulorhexis? No. Posterior capsulorhexis I will not do in all cases of polar cataract.
That's what I am asking only because of
No.
premium IOL you are doing it, or
Only
you are doing in
because
all cases.
not necessary in all premium IOL. If the PC is intact, then why would I do PCC at all?
It
I
was
would
not
place
intact over here.
if the PC is not intact, in this particular case, I was lucky to manage a PCC because the PCR which was there from the beginning did not enlarge at all because the surgery was so careful. There was not much fluid ingress and there was no AC shallowing and all that. Those things, even with all the precautions, sometimes suddenly there's a rip of the posterior capsule. So actually, even if we have promised a premium IOL to our patients, we should have told them in the preoperative that you might change a decision on the table. I think all of us must be doing it in our practice. We are not cannot even promise a toric IOL to them. We should tell them beforehand.
But you manage it very well. And that you did a shallow vitrectomy as well. Then you manage the IOL very well. So thanks for your wonderful presentation.
Thank you.
And all the best for your election as well.
Thank you. Thank you so much. Thank you. That's the most important thing, actually.
That's what he introduced.
No problem.
You by saying this, you are contesting for the post of vice president as well. Although I am aware of this. That's why good luck and best wishes for the election as well.
Thank you. Thank you so much. Thank you.
That's all from my side. Okay.
Thank you. So, Pranav, we should move to the second topic.
Yes, sir. Yes, sir. We'll move to the second topic. The second presentation will be by Dr. Prakash Gupta, sir. He's the managing director at GLR Memorial Hospital. He's a renowned surgeon in Jhansi, and he is one of the most experienced surgeon who operates in Jhansi at this particular time. So, Dr. Prakash Gupta, sir, he will be talking about ACIOL implantation, perfect prognosis of more than 300 cases.
Yes, good evening, everyone, and thank you for giving me time for this presentation. Basically, this video is just a message to all new ophthalmologist or entry segment surgeon. Basically, everybody is fearing of this which is a PCR and which is coming in AC. What to do? Should we leave it to some posterior segment surgeon to put in SFIOL? So this is the biggest hurdle. So I just randomly recorded this video, just giving a message to everyone. The ACIOL, since last, I think I'm putting this ACIOL since last 30 years. It's more than 300, or I don't have count for that ACIOL, but I never saw any corneal decompensation in these cases because I always did a vitrectomy with two peripheral iodectomies, and always patient came in a very good position. So that is my message. The video you can see is there. I think video, Dr. Salni, I think video is with you. Video.
Yes, sir.
Do you have video? Oh, I should have play.
Okay. So, sir, आपका video is, you want me to play?
Yeah. In fact, I never played this.
Okay, sir, fine. So what I will do, in the meantime, we can start another presentation. I will forward the video to Dinesh ji and he will play in after next presentation, okay?
Okay. So I'll ask Dr. Gaurav Mishra. He's the director at Drishti Eye Center at Meerut. and he will be talking about new paradigm in cataract and vitreoretinal surgery with Unity system. Gaurav sir.
So the latest thing in the market is 4D now, and I'll be talking about that. So I'll play three videos in a short duration of time, just to let you know that how it feels when you're operating on a Unity system. So this is a small pupil, not dilating, even with the intracameral. I'm not putting any hooks. This is a fairly harder cataract. The advantage of this machine that this is very stable, it is very fast, and the energy used is very less. You can see even in the harder cataracts, we have done more than 200 cases now in the last 1 month. It is quite an early thing to be used at our center. And I find this system as a very good system, even with my harder cataracts. And my phaco time has gone down. So this was a cataract, old aged patient, myotic pupil, not dilating. I didn't use hooks. And you see the stability. I am not moving my main handpiece much, and still everything is coming to the port. So that is the beauty of the machine, that you just crack the central part and everything comes by itself. You just have to move a bit. So this is one of the harder cataracts which we had done recently in a non-dilating pupil without any hooks, and the result was absolutely fine. You can see the power that I have used, and the important thing which I want to convey through this is that after the surgery, when I saw the template, I was surprised myself that the uh, so so the template you can see here, that this shows that phaco time which was in such a hard cataract is just 10.16 seconds, and my average time with softer cataracts lesser than this are 1 or 2 seconds now. And you can see the equivalent average FP3 is 10%. That means only 10% of the 100% of the energy is used. And when I kept my phaco power at 40%, only 25% of that 40% was used. So the total duration has gone down. The energy used has comparatively gone down a bit. So I think this is a good thing in my scenario, since I'm using it for last 1 month. And after this, I'll put one more video. This is slightly softer cataract, and see how beautifully it cracks the nucleus. The holding power is very good. And I do not use the torsional or the longitudinal. They both are zero in this. And in this, the average time which I take is hardly 2.76 seconds, I suppose. Let me put the template after this. So if you see the template here, the phaco energy is just 9. And the total duration, CD, which we call as, is 2.79, which have gone down to 15 or 16 in my normal surgery time. And the equivalent average FP3 is 8.9% only. So what I want to convey is the advantage of this machine, which I found with my normal machine, was that my phaco time has reduced, the phaco energy has reduced. I'm still comparing the results of my pre-op and the post-op endothelial cell count. So these are the 2 or 3 cases which I wanted to show you about this 4D phaco, which is latest in the market, and I am very comfortable with this. So this is my last video of a comparatively very hard cataract. I'll go through this very fast. So you can see that this is a comparatively very hard cataract, and this comes out like just a piece of cake with this machine. And here also you can see the equivalent FP3 is 10.6% only.
and the phaco energy uses 28.9. So I would be very happy if I get a lot of questions from the viewers and the panelists and the speakers also. Thank you so much.
Thank you, sir. Again, excellent video, sir, that you've presented. The only problem with Unity is that it is too expensive. But it's great that you can.
No, it is too expensive. But with the vitreoretinal system also, if you are a vitreoretinal system,
Yes, sir.
the advantage with the vitreoretinal system is that it has cuts up to 30,000. So my retina surgeon who is doing retina surgery says, sir, it is
Very
like just like driving a Ferrari car. So we are used to the normal cars, but once you sit in a Ferrari, you feel the difference. And obviously for the Ferrari, you have to pay a price.
Yes, sir. So I would request Professor Adib Alam Khan, sir, to comment on the video, and Dr. Lakshmi Singh, ma'am. Adib, sir.
Yeah, congratulations, Dr. Gaurav. It was a very excellent presentation and wonderful that, like you were talking, you can afford the Unity system. Not even, institutes can dare to do that now. What I wanted to know is that why at all did you feel that you should, upgrade and move to this Unity system? What was so great about 4D? कुछ आप advantages बताएंगे उस केस में?
मैम मैंने दो चीज बताई. फर्स्ट ऑफ ऑल माय फेको सर्जरी टाइम हैज रिड्यूस्ड फर्स्ट.
Yes.
Secondly, it is a faster system. It is a newer technology, and sooner or later we'll have to get to used to these new technologies. Earlier we were not used to. We were having simple phaco techniques. Then came the torsional, and now the 4D. So sooner or later everybody has to evaluate. Don't go for the price. It is going to come down sooner or later as the market grows. But you see the advantages with it. The only thing I am worried about is I'll have to see how much is the endothelial cell loss. Two things I have seen. One is my phaco time has come down, phaco energy has come down, and followability is very good. The only thing I am is waiting is first 1 month I'll have to see how much is my endothelial cell count differentiated between the normal Centurion and this machine, because I have Centurion also. And now I am working shifted to this. So since I have shifted to this machine, I found it very easier to shift to this machine after doing my Centurion machine.
What was it, that technological difference between Centurion and Unity?
What is 4D?
Basically, it is only the quantity of nucleus fragment eating up first time. If you are eating 50% of the nucleus in 1 second, this will go to less than 1 second if you are eating the nucleus in the same period of time. Plus the energy consumption is lesser in this. That is the most important. So I suppose if the energy consumption is less, the endothelial cell loss would be lesser.
No, how is it? The phaco tip vibrations explains it, or what the fluidics?
It is absolutely the same, ma'am. The eating of the nucleus is much faster as compared to the torsional phaco. That is one advantage I found. So basically, if your eating is faster, definitely your energy would consume would be lesser. That is what my thinking is, and the endothelial cell loss would be lesser. So Karan Bhatia, who is working with me, he did 1 or 2 cases in a compromised cornea.
The cycle time.
Sorry? Is there a background? Somebody was saying something?
No, I think somebody is asking about your effective phaco time, I think. That was
Ma'am, I was saying that the cycle time between the vibration that has decreased, so the followability is much more. It is holding on the nucleus much better now, and that is what is decreasing the time.
Yes.
There's no chatter happening.
So Gaurav, I believe you have done several cases on this new machine, right?
Yes, ma'am.
And when you switch to this machine,
Yes, ma'am.
As everything is happening much faster, your phaco time has reduced, your nucleus cutting time and followability is more, so that time has also reduced. So in the beginning, did you feel कि ऐसे जैसे कभी कभी सर्जरी करो ना तो लगता है अरे जल्दी जल्दी काट रहा है, कहीं वहां ना चला जाए, कहीं यहाँ ना चला जाए.
Exactly,
So
ma'am.
that kind of apprehension with such a fast machine might have been there.
Ma'am, initially 50 cases mein, this was the problem. That when I embedded it, it was
Yes.
going through the nucleus in such a fast that I thought I was touching the posterior capsule.
Yeah,
So
suddenly you find
initially,
that you are near the posterior
yes,
capsule. Yes.
yes. So we had to be very cautious, and the people were with us. They guided us that initially, if you are doing phaco on a Centurion, please be very slow when you are doing on this machine because it cuts very fast.
Yes.
So we had to go very slowly in initial stages. But now, since we have done a number of cases, we are quite comfortable with this.
So I believe that that would be a guideline for people who are switching or in the process of switching. That I mean, it would be much faster than the Centurion that we are used to. So go slow,
Yes.
at least till
Yes,
you
ma'am.
get the feel.
Even
Ma'am, even in the harder
parameters
cataracts.
will be low, no?
Sorry?
Your parameters will be low, I think.
Yes, ma'am. Ma'am, initially, even in harder cataracts, it went through the cataracts such fast that we had to be careful.
Well, very good. Technology is evolving and so are we, but we have to be very cautious with every new technology.
Yes, ma'am.
So what about the phaco needle? Is it the balanced one, or is there
Same
any?
as it is the same as Centurion, and the Centurion handpiece can be put into this also. So the Centurion
Everything is
handpiece
compatible.
with this, but the handpiece is different. It is a 4D handpiece.
One thing,
So what is 4D exactly?
one thing is, whenever
It is the movement of the tip. Like in torsional, we have this movement. In this, we have movement like this. So it moves in all the directions and eats up the nucleus fast.
What? It is a combination of ellipsoid and
Yes, yes, ma'am. You are absolutely right.
Dr. Gaurav, one question. During surgery, I saw that your ports from where the fluid was coming, from the phaco port, was coming from the top. Normally, we keep both the foot on the side. But I saw.
Sorry. Abhishek, I cannot hear you.
no, he says that the two apertures on that phaco tip, he says that you are holding the phaco tip differently. Was it so?
Yeah,
I
yeah.
thought using it
The
normally.
tip was facing the cornea.
Was there?
No, I don't think so.
No, I don't think so.
You can go back to your video. Show you.
Okay. I'll see to that. But basically, I changed the direction of my phaco needle if I need to do so. We can move
I
on.
have
And we
one
can,
question, Dr. Gaurav.
yeah.
Can we attempt total black cataract with this machine?
Definitely.
Because we are always apprehensive with this cataract. We can't do it with basic machine, intuitive or Centurion. But and we always convert such cases to SICS because it's really, it's very fearful attempting total black cataract.
No,
So,
you can
have you
easily
done
do it.
any case of total black cataract with this fantastic machine?
Not total black cataract, but I have done leathery cataract with this machine. And as I was telling earlier also, that once you start using this machine, you'll see the difference. It is so fast. It embeds very fast and it breaks up the nucleus into pieces, even in leathery cataracts. I haven't done a black cataract as you, but I think it would be done with this machine.
So what is the difference you found between Centurion and this machine regarding a soft cataract? Was there a major difference or is it more or
No, Charu, I think there was not a much difference in softer cataracts. It was same as Centurion. but definitely because we also get harder cataracts most of the times. So I think it is better for harder cataract, but softer cataracts, it is the same as the Centurion machine.
So,
Thank you, sir.
thank you so much, sir.
Thank you.
So, if Dr. Prakash Gupta sir's video is ready, then we can see it. Dinesh, tech support.
Otherwise, we can move to the next topic and then we can
Yes.
come to Dr. Prakash Gupta.
Sure, sure. So, the next presentation would be by Dr. Rakesh Shakya, sir. He is the head of glaucoma services at Sadguru Netra Chikitsalaya, Chitrakoot, and he is known to be one of the fastest surgeon in India. And his topic would be converting to MSICS in challenging situation. Rakesh Shakya, sir.
Please actually stop the sharing the previous talk. So my screen is visible?
Yes.
Yes, sir. Yes.
Yes. So thank you, Pranav and Professor Salini Madam and Dr. Prakash Gupta and Abhishek Chandra to give the opportunity to me. And this is actually regarding this case. Actually, I'm doing this cataract. It is the hard intumescent cataract. So actually, when I operating, I just the video is working. Video going on.
Yes.
Yes. So after actually making the port in this case, actually I try to make a slightly bigger axis about 5.5 mm. And this is actually you see, this is the grade 4-5 cataract. It is slightly harder in nature and it was intumescent. So I actually removed the cortical part and loosen the cortex and then try to rotate it properly. What during the rotation actually is slightly difficult. So I take a 2 Sinskey hook and then after that we make a slightly deeper trench in this case in the both side. And after that, actually, sometimes I make a trench in the crusade fashion in the when the cataract is slightly harder and go in the 80% of the depth. When the slightly red glow is seen and then try to crack it. And the first crack actually was very good. And as you see, and then during the second crack, I feel slightly resistant like that. So I hold again the nucleus. And then you can see sudden deepening of the antechamber and the red glow is actually slightly seen. I can see and again actually you can recognize, you can just rotate cracking, just red glow is seen at the sudden deepening of the antechamber. So I just keep the biscope from the side port and then remove the actually probe. And so actually I in mind actually whole nucleus in the bag. So how can actually proceed further in this case? So I saw the one piece of the nucleus slightly loosened. So I with the help of the Sinskey hook, I just lift this piece in the anterior chamber and then put the bisco and then I decided to convert in a slightly bigger tunnel because the nucleus slightly bigger. So after making the tunnel, and then first I actually remove this part, quadrant particle, and then I make a two actually port. In this case, another port. So we make to take a 2 Sinskey hook actually. And then another Sinskey hook actually take to support the nucleus because sometimes the nucleus rotation it can go on in the vitreous cavity. So I just support with the help of the two hand and then rotate the nucleus in the antechamber and then actually remove it and do the thorough vitrectomy in this case properly. So after the vitrectomy, I just see the some part, cortical part actually remaining. So I just remove it with the help of the Simcoe cannula. So after the removing the cortex and do the vitrectomy again, because the some actually fiber is remaining the vitreous cavity. So just I clean it and put the some amount of the visco behind the iris, and then put the 3-piece oil in this case. So after the putting in the sulcus, then it actually capture it properly, and then tunnel actually I always actually suture it sometimes, and then hide it properly. So actually my
Wonderful
actually
surgery.
mainly is that when you're operating this type of the hard cataract, and if you actually find some actually PCR during the whole nucleus in the back, so how to proceed in this case? Actually, you should be slightly calm and then go proceed how to actually convert in this case.
Yes.
Wonderful surgical video, sir.
Wonderful surgery. Wonderful. I think the important thing here is that if you are sat temporarily to do your cataract surgery, and with this large nucleus making a big incision, I think you should shift superiorly and do your SICS,
Yes, sir.
and then get the piece. But supposing
I,
you have already two pieces, and then maybe you could even make a temporal sclerocorneal tunnel and remove it. Because the tunnel.
I always, madam, make a because I'm very used to make a scleral tunnel.
Yes.
So why this reason I always shift toward the superior side and always make a tunnel. Sometimes during the much vitrectomy, the actually the globe becomes slightly softer in some cases. So you can go. You should always take a slightly sharp blade, so you can make a slightly tunnel and then goes very easily. And if the nucleus is hard, you make always make a slightly bigger tunnel is very important. And that actually in this cataract, the most important thing is how to recognize the PCR is very important, because sometimes the during the cracking, some surgeon actually don't recognize. So in this case, actually the sudden deepening of the antechamber and red glow is slightly increased,
Yes.
and sometimes the fluidity also lost. So in this case, the luckily part is that the vitreous is not disturbed much during the cracking.
Yeah.
Very important point.
Supposing that PC had opened up when little bit of the nuclear fragment is eaten up by phaco, and you had a vitreous PCR later, little later, you can even place an IUL scaffold and do it.
Yes, if the
Here it was
nucleus, yes, ma'am, if the nucleus part is small, then we can do the scaffold technique. But nucleus is very bigger, is to try actually better to convert it.
Yes, better to
Actually, I think that was a very, very beautiful surgery. And as you very rightly said, that the crucial point is to recognize the PC rent.
Yes.
And the points also are very nicely conveyed, that the change in the feeling of the AC and that change in the glow and deepening of the chamber. But the most beautiful part was a quick decision to convert to a SICS, because if you struggle at that time with the nucleus, you will disturb the vitreous more and land up also in nuclear drop.
Yes.
So very beautifully done, and I think that was very, very wise to convert to SICS. There is absolutely no harm in converting to SICS.
It's very rightly said. Yes. Recognizing this PCR is very important at right time. That is very important, because then you can think of managing it and converting. That is very aptly done in this case. Congratulations, Dr. Rakesh.
Thank you, sir. Thank you,
Yes,
sir.
very good, Rakesh.
And
excellent surgery.
Dr. Rakesh.
Thank you, sir.
डॉक्टर राकेश,
Yes, ma'am. Yes, sir.
ये आप जैसे जब न्यूक्लियस को जब डिवाइड कर रहे थे,
Yes, sir.
तो उसमें आपको रेजिस्टेंस फील हो रहा था?
Yes, sir.
हाँ, तो क्या रीजन था?
Actually, during the sculpting, actually the improper of the judgment actually to crack it. It is the one more important thing. And during the actually cracking, the heminucleus actually separated too much.
Yeah, yes.
So why this region the PCR occur?
Yes.
Because the nucleus is slightly hard. Actually, during the cracking, always crack slowly in the actually the
Okay.
gradual manner. It should be better. So actually, in this
I
case,
think
I
it has
did
to
this
be
slightly too much cracking it.
Yes.
Slowly,
yes,
and
that
the distance
we
should
can
not be
avoid.
so much.
Yes, sir.
Distance should be
Distance
less.
slightly, not no, just crack it and then go gradually. I think.
But doing a
That
4 quadrant, there was no harm. These are
Yes, sir.
surgeries where I would have also done all of this only. Yeah.
No, this the divide and conquer technique. It can be done in the all type of the cataract. I think.
Yes.
For harder cataract,
Yes, we have
doing a
handled
vertical
very
chop.
hard cataracts with divide and conquer technique. You only need to be a little patient.
Yes.
Doing
And
a
I
letter
think
separation and a direct vertical chop works really well because it
Yes, that's
doesn't
what I'm
put
saying.
stress on the zonules. When you are
Yes,
trying to
ma'am.
divide, it doesn't have any stress on the zonules. Just hold and divide it vertically, chop it. That really helps us manage. And a lamellar separation, just taking out the center nucleus, then separately, really works very well in such cases.
Yes, ma'am.
And I think the judgment was
that's
so
it.
good because, sometimes when you're dealing with hard cataracts, white ones, and you crack and you see a red glow, you think everything is okay because this red glow seems okay. It's not like it's a severe, a jet red glow or like that. So the judgment was so nice that you could pick it up so early and then, manage it so well.
Thank you, thank you. And one thing
Beautifully
is
managed.
that I just added that when you actually operating the any complicated cataract or any hard cataract, you should keep the SIS set in the inside your table always.
Yeah.
Yes, Dr. Rakesh. Nice
Thank you
presentation.
so much, sir.
Thank you, sir. Thank you.
So, wonderful presentations till now. So, we'll move on to the next presentation.
May I
Uh,
say something?
Yes, ma'am.
yes, ma'am.
यदि हम इस केस में डायरेक्ट चॉपिंग करते तो we could have avoided this complication,
Yes,
vertical
ma'am.
chop.
It may be possible.
क्योंकि when we are dealing with such cases, hyper mature cataract, there are always chances of weakening of posterior capsule. There are chances of weak zonules. So in such cases, vertical chop, I think, is a better technique than 4 quadrant cracking.
Yes, ma'am.
Great, ma'am. Very important points.
Because
And
I always prefer, matlab, in my every case, I do vertical chopping only.
Yes.
I never do
I
4 quadrant
always
cracking or stop chop.
I used actually the stop and chop technique in all cases, but in sometimes I use the divide and conquer in some cases.
But in this case also, you never know, you may be dealing with a posterior polar cataract as well. I mean,
Exactly.
could be
Yes.
a possibility.
Exactly. Very true. Even I thought that.
Yes, ma'am. Yes, ma'am.
Very well managed, though.
But
Thank you.
very well managed. That is the point. Okay, there was one separate part of the nucleus, and you took the one. Then later on, you took rest of the part. So
Is there
that is
any
managed very wonderfully.
pre-op assessment we can judge? Is there any posterior polar cataract?
Anterior segment OCT.
Yes.
Yeah.
ASOCT can be done,
With,
but
yeah,
actually
with,
in our scenario, madam, it is not possible because we are working in the very high volume center. And we
Mhm.
can't do in the because
with,
the 50% cases the hard cataract here.
And man,
During
sometimes
doing,
it is really difficult to, catch the dehiscence part in OCT. I mean,
No.
isn't it?
ASOCT you can make out. There's no problem. क्या एक बायोमेट्री तो करते हैं ना, तो उसके बगल में एक ASOCT रहेगा तो कर सकते हैं.
हाँ, इसमें I think with the femtolaser cataract surgery, when you scan the nucleus,
That time
then you
it's
can see the picture defect in the posterior capsule.
Yes.
You can recognize.
True.
And second, if cataract is immature in other eye, you may know कि other eye में क्या condition हो सकती है. And
Yes,
third
sir.
is अगर पहले की कोई सर्जरी हो चुकी है and pupil is not round या कुछ लगता है, then you can assess there is a possibility for polar cataract in
तो
other eye.
ऐसे केसेस में सर फेमटो लेजर ज्यादा हेल्पफुल रहता है?
डेफिनेटली बल्कि मैं तो ये करता था कि ओपीडी में जिसमें होता था और फेमटो लेजर नहीं करना है, वो पे नहीं करता था, तो मैं उसको पहले मैं स्कैन कर लेता हूँ।
अच्छा,
क्योंकि उसमें हम एक ही बार हम शॉट लगा सकते हैं।
ओके,
तो स्कैन करके अगर हम बैक होता है तो 2-3 पेशेंट में स्कैन हो जाता है वो। फिर फाइनली जिसने पे किया उसमें फिर उसमें फेमटो कर देते हैं।
Okay, it's very well.
नाइस फ्रेंड्स।
Thank you, sir.
Yes.
Thank you, sir. Thank you, ma'am.
Sir.
Voice is breaking.
Voice is not coming properly. Pranav, voice is not coming.
Pranav, voice is not coming.
So if the tech support is there, we can move to Dr. Prakash Gupta's video.
I have two videos. This is traumatic aphakia. This patient was 32 years old. 15 years back, he had a trauma. And he was operated somewhere. They did the proper vitrectomy, then left it as such, aphakic. तो ये केस अभी आया मेरे पास, और हम ऐसे केसेस में भी मैं एसी आयल डालता हूं, जो मैंने अभी मैसेज दिया। ये बेसिकली वेरी सिंपल सी सर्जरी है, हर कोई करता है। नथिंग ग्रेट इन दिस सर्जरी, दिस इज वेरी सिंपल, एवरीबडी इज डूइंग, fearing that ACIL is not good for the patients. बट मेरा एक्सपीरियंस बहुत सारी सर्जरीज का है। मैं ट्रॉमेटिक केसेस में भी डाल रहा हूँ, मैं एक्टोपिया लेंटिस केसेस में भी मैं विट्रेक्टमी करके आयल डालता हूँ, और मुझे कभी कोई प्रॉब्लम नहीं हुई, कभी कॉर्नियल डिकम्पोजिशन नहीं मिला, कभी प्रेशर राइज नहीं हुआ। मेरा मैसेज ये है केवल इस बात के लिए कि हर एंटी सेगमेंट सर्जन ये सर्जरी कर सकता है। SFIL हर जगह अवेलेबल नहीं होते हैं, हर डॉक्टर उसको कर भी नहीं सकता, तो क्यों ना ACIL को भी रखा जाए। मैं तो पिछले 30 साल से कर रहा हूँ, मुझे नंबर भी याद नहीं, शायद मेरे बहुत सारे कई हंड्रेड्स में है, बट आई नेवर फेस एनी प्रॉब्लम विद दिस, एंड दिस इज ट्रॉमेटिक, यू कैन सी दिस इज वेरी कंफर्टेबली आई एम डूइंग, एवरीथिंग इज गो वेल। एंड एम्ब्लाइपिया था इसमें, मैंने आयल डाला, previously vision was hardly 1/60, and then after surgery he got 660 vision next day। अभी ये 3-4 दिन पुराना 7-8 दिन पुराना केस है, अभी फॉलोअप में नहीं आया है, बट ही विल डू गुड। तो मेरा कोई, मैं बड़ी सर्जरी नहीं दिखा रहा हूँ, मैं केवल ये कह रहा हूँ कि एंटी सेगमेंट सर्जरी सर्जन्स को ये चीज करनी चाहिए, ACIL से डरना नहीं चाहिए। जहां फैसिलिटीज अवेलेबल हैं SFIL की, वो ठीक है, अदरवाइज नहीं है तो अफेकिक उनको नहीं छोड़ना चाहिए। थैंक यू।
Thank you so much, sir. Wonderful presentation. So I would request Dr. Anand Sharma, sir, to comment on the video, and rest of the expert panelists.
Yes, Dr. Prakash, you have managed it well. I have also used AC lenses, never used, in fact, SF lenses.
Yes.
And for all practical purposes, if done well, not leaving any vitreous in AC, they
Yes.
don't cause corneal decompensation.
Yes.
I would say that this was a very good video, and it was a Kelvin type of anterior chamber IUL.
Yes, ma'am. I'm putting the same.
I think the older surgeons have experiences with that. The only word of good experiences. The only word of precaution is that we should not forget to do an iridectomy while putting this lens.
Yes, you are right. Very right.
Because without that, there is a problem.
Without that, only on cable you can feel problem. Entry chamber will be shallow. You will not have a entry chamber formed entry also table.
But
So does
very
white to white
clearly
matter
said
in
that
these
one should
cases?
do the peripheral iridectomy in all such cases.
Yes. Peripheral iridectomy, proper vitrectomy.
Yes,
Two
yes,
things
that
are
is very
important.
important. Yes.
और अभी तो हम लोग के पास विटेक्टमी है पिछले 20 ईयर्स से 25 ईयर्स से उसके पहले तो विटेक्टमी नहीं थी तो हम लोग ड्राई वेट वेट सॉरी ड्राई कॉटन से विटेक्टमी वेनस सीजर से और डिवेकर से करते थे
ओपन
तब भी ये
स्काई
डालते थे
एक्चुअली अब
Congratulations, sir.
ईसीसी और फेको हम लोग करने लगे हैं रूटीन में. ईसीसी भी अब खत्म हो गया, एसआईसीएस और फेको करने लगे हैं, तो आयरिडेक्टमी करने का रिफ्लेक्स खत्म हो गया धीरे धीरे. दैट इज वाई आई पॉइंटेड आउट कि जब भी ऐसी टाइप ऑफ आईओएल डालें तो आयरिडेक्टमी करना भूलें नहीं.
हाँ देखिए अब तो हर एक के पास फेको है फेको हर कोई कर रहा है और आयरिडेक्टमी इज वेरी सिंपल विद विटेक्टमी प्रोब वेरी सिंपल.
So this element type of ACIOL, it's also important that we identify the side of the IOL, the vault up, and the AC should be very well formed at the end of the surgery with the haptics nicely in the angle, not causing any trauma. I think those 2 points will always keep the eyes healthy and the cornea also.
But that was very good that Dr. Prakash pointed it out that this is also a very good option.
For every simple entry
It's a
segment
simpler
surgeon.
option.
Yes, simplest one.
Sir, I would like to make a comment.
I noted that you had used air. You did not use viscoelastic while putting in the ACIOL.
Most of the time I use air.
Acha, that was really commendable. It is rare to see that normally.
But do you leave air after surgery in all cases?
Yes, I leave air.
Yes.
And
you
give one
suture?
suture also.
You suture in all the cases.
Yes, yes.
Dr. Prakash, just one question. Sir, I have been using ACIOLs, these Clelman types, for a long time. But recently I shifted to the retrofixated IOLs, the iris claw ones. And I think that would be a better option for the newer surgeons to learn to use the retrofixated iris claw lenses because they are very easy to learn.
You are
Simpler
right.
than the
You are
simpler
right.
than the ACIL.
No, definitely. But ACIL, in fact, we are doing since last 30 years this Kelman IOLs. So we don't have any problem with that. ठीक है वो भी आ गया था आइरिस क्लॉ भी आ गया था वो भी कर सकते थे लेकिन वो हम लोगों ने नहीं किया नहीं कर पाए या किया भी नहीं अवेलेबिलिटी भी नहीं थी हम लोगों के पास उस समय.
नहीं सर मेरा कहने का सिर्फ एक मकसद है कि अगर हमने किसी को पीसीआईएल कहा है एंड वी आर डूइंग कैटरैक्ट सर्जरी तो अगर आप रेट्रोफिक्सेटेड आइरिस क्लॉ लेंस लगाएंगे तो दैट विल सर्व द पर्पस ऑफ द पीसीआईएल रादर देन पुटिंग एन एसीआईएल. That is the point I wanted to make, and that it is the one that should be learned by the younger surgeons. If they are planning to put in a PCIOL and they put a retrofixated iris claw lens, that would be a better option. That is what my point was.
That is better, of course.
So definitely,
But
Dr.
that is
Gaurav, I
not
also
possible
feel the
every
same.
surgeon. वो हर सर्जन के लिए पॉसिबल नहीं है.
You see,
ये
there are
ACIL
so many
हर कोई कर
techniques,
सकता है.
there are so many techniques and even there are many more minor modifications which are being used by all surgeons.
Yes.
See, one should have all the techniques at hand and then choose the best. That is one. And one technique may be very good in my hands, may not be so good in someone else's hand.
Yes,
And
definitely.
same is true for that another technique being very good in someone else's hand, and I would say no, this is not good. That is just a method of individual preference. The idea is to be aware of all the possible good techniques and use them at your own discretion.
Yes, definitely.
Dr. Prakash, my concern was that sometimes I have seen after 1 year, 2 years, or 5 years after putting the ACIOL, you get angle closure at that places. Sometimes there are significant chances of uveitis, which are not there with retrofixated IOLs. So I would preferably feel that retrofixated IOLs are better, and that has low complication rate as compared to ACIOL, as Dr. Gaurav said.
Definitely, he's right. But I have hundreds of I've done hundreds
He's
of
talking of his
ACI.
experience, yes.
एंड मेरा एक्सपीरियंस हमेशा अच्छा रहा है, कभी मैंने कोई प्रॉब्लम ना तो आईओपी राइज करते हुए नहीं देखा, कॉर्नियल डिकम्पोजिशन नहीं देखा। अच्छा, बस ध्यान इसी बात का दिया कि विट्रेक्टमी प्रॉपर हो जाना चाहिए, एसी को डीप हो जाना चाहिए और पेरिफेरल एडिक्टमी जरूर होना चाहिए दोनों तरफ। मैं सिंगल तरफ भी नहीं करता हूँ, दो तरफ करता हूँ।
शाक्य सर?
Actually, sir, sometimes actually I am also doing the glaucoma part. So actually I saw the many cases, actually more than 100 actually ACL actually I explanted. So then actually I think when actually I at some points when we consider the ACI, because it is the very cost effective and you can it is very faster and the chances of the hypema and they are very less. So when we consider, I think the adequate antechamber depth is very important. And previously, healthy cornea is very important, and stable iris position also is very important. And absence of any anti-segment pathology is also very important. And also assessment the what is the capsular actually support. And so the why this region actually these are the some points actually keep in mind when you actually putting the ACI, because it is also the alternative, because now all surgeon actually shift, also me also shifted to the SFIL or the retrofixative iris claw lens, because the chances of the complication is slightly less, but the your experience is very good. It's okay, but in the some cases actually when we do improperly, because when the antechamber is depth not or it is associated with the corneal pathology, it will actually land up of the some complication after the 2 or 3 years. So why this reason actually you should keep in mind some situations also. Thank you, sir.
Yes, I agree that. But the proper protocol should be kept in mind, like vitrectomy, make AC deep, and do this alectomy. You will not face any problem. एंडोथेलियल सेल काउंट तो फिर देखिए हर पेशेंट में हर जगह स्पेकुलर माइक्रोस्कोप अवेलेबल नहीं है, तो आप देख नहीं सकते, आपको अंदाज ही करना होता है सारी चीजें प्रैक्टिकल लाइफ में। जब करते हैं कोई चीज मिसहैप हो रहा है आपके सामने, तो आप मैनेज करके उस समय दे दीजिए जितना बेस्ट मैनेज कर सकते हैं।
Sir, just few
but we can see the corneal clarities, no problem.
Yes.
तो जब केस सिलेक्ट करते हैं आप कैटरेक्ट सर्जरी के लिए, तो वो हम लोग तो वैसे ही देखते हैं स्लिट लेंस से ही, स्पेकुलर माइक्रोस्कोप मेरे पास तो नहीं है और मोस्ट ऑफ सर्जन के पास नहीं है।
Most of the surgeons, they don't have a specular microscope.
यस, तो हम लोग कॉर्निया ऊपर से कंडीशन देख के ही डिसाइड करते हैं कि सर्जरी करनी है।
Sir, just few questions कि IOL power, what is the IOL power that you consider in these
ये
cases?
नोडल पॉइंट से थोड़ा आगे है, तो हम लोग प्लस 1 डायप्टर डाउन करके नंबर लगाते हैं। सपोज 20 नंबर है तो हम उसमें 19 या ज्यादा विट्रेक्टमी कर दी तो 18 पावर डाल देंगे।
A constant is written on that accordingly.
ये A constant भी लिखा
You
होता है,
don't
दूसरी
need to
चीज
calculate the
नोडल
power.
पॉइंट से
A
थोड़ा आप
constant
आगे
is
आ गए हैं।
written there on the box, IOL box.
Yes.
Okay, so moving on to the next speaker, Dr. Manish Mahin.
Thank you.
He's a cataract and refractive surgeon at Kanpur and Khairabad Eye Hospital and Mahindra Eye Institute. And his topic is when IOL turns white, a surgical dilemma. Manish sir?
Is it audible? Am I audible here?
Yes,
Yes, sir. Yes, sir.
Okay, so at the outset, I would like to congratulate the UPSOS Executive Committee for this wonderful initiative for starting this monthly webinar. And this will not only help, in knowledge sharing and learning, but will also help us to stay connected. So I'll be talking on a very important topic. This is the IOL opacification, when the IOL turns white. And I think we all have faced this problem in our practical, in our clinics. And I think, with the use of these hydrophilic acrylic material lenses, and some companies, they have some maybe material or something, we get to see such kind of, cases where the lens has completely opacified. It's like a white. So this was a case of a 73-year-old female who presented to us and was operated 5 years back, and we had this case. So I started off with my iris spatula. I'm going underneath the rim of the capsular axis and dissecting it so as to break the adhesions here. So you have to go all around it in a 360 degrees manner circumferentially so as
So
to
the
break.
screen is not visible.
So your video is not visible.
Really?
Yeah.
Yes.
The video is not visible.
No.
No, sir.
Just a second. Is it there now?
No. You should have shared, you should have opened up your presentation before you open the Zoom link.
Yes, sir.
Okay, just a second. Just a second. Pamni. Video is not sharing.
मनीष शेयर वीडियो में जाओ मनीष शेयर वीडियो में जाओ
Yeah.
Can you open the video, Papa?
Post-COVID, all our children are helping us do this. For all
Is
of us,
it playing now?
No,
No,
it is
actually,
not.
first you copy the video on desktop and then
Yes.
open it and share it.
You can log out and just open the video and then log in. At that point, also you can share the screen.
Oh, put it to desktop. Okay.
Put it desktop.
There's also a small option once you open and start sharing the screen, where it says that allow sharing videos. If it's not clicked, then also it won't play.
I share the screen.
Yeah.
Now it's coming?
Now it's coming. It's coming, sir.
Okay. Can you see the video?
Yes, sir. Yes.
Okay. So, one second. Okay, so I'll be talking on the IOL opacification. So this was a 78-year-old female with the lens opacification, and we start here with an iris spatula. So I'm going underneath the rim of the capsular axis, and I'm dissecting it completely all around, 360 degrees circumferentially. I think this is very important there so that you can break the adhesions here, whatever is there. And you have to be very meticulous while you're doing this. Use lots of viscoelastics, or you can use a cohesive viscoelastic here. I make another side port for my another instrument. And this is followed by a visco dissection here. So I go underneath the rim and then inject visco all around it so as to again break the adhesions. And as I do so, you will see the adhesions being moved. Here you can see the adhesions are breaking now. And then with my Sinskey hook, I de-enclavate one side of the haptic and try to bring it into the anterior chamber. Similarly, I do the same thing on the other side and lift it up and bring it into the anterior chamber now. Now here I use my intraocular lens cutting scissors, and with this Sinskey hook I stabilize my lens, and I'm cutting the lens right in the middle, but I won't cut it completely. I'll cut it almost till the end, like like a Pac-Man opening, and this will facilitate my removal. Now I will rotate, and now I will holding the lens holding forces. So I remove one part of the lens, and this is followed by the removal of the other part. Now the lens has been removed. This is followed by the removal of the cortical remnants, and then some PC polishing. Now I have a nice PC, and then this is followed by implantation of hydrophobic acrylic lens, which can be placed. Now the trailing haptic is being placed in the bag. So you have to be very meticulous, so that you don't, compromise on the capsular bag, and be very gentle. So the viscoelastic is now being removed from above as well as behind the lens, and We have a nice lens right there in the center. This is followed by hydration of the side port as well as the wound. And this is how the case was. This is first post-op day. The patient had a 6/9 vision, and patient was one-eyed actually, so she was very, very happy. I have other cases, but I think we don't have that much time because I'll just fast forward it. This was another case in which I just lifted the lens, brought it into the anterior chamber, and I now remove it completely. You know, these are very flexible lenses, so sometimes you can just completely remove them in toto, and you can see how wide the lens is here. And then you can implant the hydrophobic lens. And I have just one more case in which we had this. You can see sometimes you may deal with such adhesions also, and you have to be very careful, put a lot of visco, try to break these adhesions. And it was very difficult. And in the process of, de-acclimating the haptic, I had a zonal dialysis here. So in spite of my being very patient and very slow, still, I had this dialysis. So I somehow brought the lens in the anterior chamber, and then I pulled it out. And here I implanted a CTR. So if you have such situations, you can implant a CTR also and save the bag, and thereby implant the hydrophobic acrylic lens in the bag. So the lens is being implanted, and then you rotate the lens in such a manner so that the haptic lie in the weak zonular area so that it can stretch the back and further strengthen the back. Thank you.
Very nice
Exceptional
videos.
video, sir.
Very
Wonderful.
nice.
Beautiful.
And
Very well
each
managed.
had a take-home message. Very nice.
So
Very
that was
nice videos, but I mean, I have read about IOL getting opaque, IOLs getting opaque, but I have not yet seen. But I would just like to, I am curious to know, did you notice this opacification in some particular lenses, or could you identify or no?
No, they are more seen in hydrophilic IOLs.
Yes.
Hydrophilic, not hydrophobic.
Madam, there was one patch,
I think,
of freedom lenses, hydrophilic lens, which had these opacifications. And I have removed around 10 of them.
Yes,
in freedom as well as two-fold lenses.
I have not seen in so many years, but anyways, but one thing that I have had to remove one IOL once, and I like this technique because I did the same thing. You cut it, you don't have to cut it full, you cut it just part of it, and it kind of unfolds, and you can remove it through a very small incision.
And hydrophilic lenses need not be cut. It can be removed the way he removed.
Yes. But I think, sometimes you have to enlarge the incision a little more while removing it. So if you cut it, I think it will be better.
If you cut it not fully, you can remove it easily.
Yeah, as Dr. Vinita Madam said, even cutting it slightly causes it to hinge around the incision, and it rotates nicely and comes out. Now, Dr. Manish, that was an excellent presentation. I have two things in my mind which we generally get quite a lot of time. One is if that you have a lasered posterior capsule, then what modifications you do. And second is when the haptic is so badly stuck up that it doesn't come out. So how do you deal these situations?
I think if the haptic is stuck up so much, my take would be first I would try to dislodge it and be very patient. But if it's still very stuck up, then I would just go near it and would try to cut it and separate it from the optic.
Yes.
And then cut the optic and then remove it and let that small part of the haptic remain there, because I don't think it will cause any harm, and then you can place the lens. And
I think so. I would also do the same.
Lasered.
But as I said, I have not seen a opacified IOL.
Now it has become very common these days. Quite a lot of patients are coming.
अभी हम रिटायर हुए तो हमें अच्छा है.
बहुत cases आ रहे हैं.
Dr. Shalini,
Even after the opacification, the vision is good.
Dr. Shalini, what I did was
to remove the optic, let the
Yes.
haptic be in its place, and
Yes.
place the another lens
Hmm.
with approximately 90 degrees to the no, the haptics which had remained down. So
Right.
that made the things very easier.
Yes.
Yeah.
Very true. So,
I think with the laser one, I think again you have to be careful because, of course, you use a high molecular weight viscoelastic, and you be a bit more patient, more gentle with your procedures. Try to save the posterior capsule, not let it extend. So I think you have to be more and more cautious and more meticulous with your
So
surgery
you
when you
can,
do
you
it.
can, what you do is, you can place a single piece IOL underneath this IOL which is to be cut. That
yes.
is the final IOL. You place it after increasing the space, and this other IOL which has to be removed can be then more comfortably cut.
Scaffold technique for IOL removal.
Scaffold technique. Yes, yes.
Scaffold technique.
So that iris spatula is a great lifesaver in these cases, but sometimes the adherence is so bad that even the iris spatula doesn't pass beneath it. So what I have find the 26 gauge needle, if you put it beneath and you can find a plane from where you can dissect and then insert the
Spatula.
Yes.
iris spatula. So that way it is very, very helpful.
That is a very
And
good point, I suppose, Shalini.
another thing I would like to mention is, like, if your capsule is is not able to dissect it very well, and the space is not, you can even try putting an iris hook. If it can just fit in there, you can just stretch the capsule a little more so that you have space, and then you can bring the
Yeah,
lens up.
true.
Yeah.
Yes, yes. That's a
One
great.
question. How many of you have noticed opacification of lens in just post-op period after 2-3 hours?
No, we have not seen, but
I
I've heard of
No,
never, never, sir.
Never.
In winter season.
Oh.
no, never.
Never,
No,
sir.
sir.
Some
We have not
rigidity of
seen.
IOL, sir, for sure, but no opacification.
नहीं, जैसे ऑपरेट किया उस वक्त तो बिल्कुल ठीक था, फिर पोस्ट ऑप में जाकर के देखा 1.5-2 घंटे के बाद में देयर वाज ए opacification in the center.
So hydro.
Maybe the reaction, ma'am.
This was a
No,
hydrophilic
no.
lens.
It may be the
Reaction within 1.5 hours.
Very strange, sir. We have never seen this. Interesting also.
एक्चुअली मैंने इस जो विंटर सीजन में जब काफी जब ठंड पड़ती है, जब आप
जी
उसको जब आप अंदर इंसर्ट करते हैं बॉडी टेम्परेचर पे वो आता है,
जी
इवन ये जो अप्पा का एनस्फेरो मैंने अभी कल मैंने नोटिस किया.
तो उसके बाद वो चला जाता है.
नेक्स्ट डे फिर बुलाया उसको, नहीं
वो चला जाता
नेक्स्ट डे फिर बुलाया, वो फिर वो चला गया, ठीक हो गया.
अच्छा अच्छा.
That's what I said. It's something like fogging of a lens.
यस, नहीं मैंने ये कई केसेस में देखा
Something
है,
like
दूसरे
that.
दिन में गायब हो जाता है सुबह.
हाँ.
नेक्स्ट डे बिल्कुल गायब हो जाता है,
बिल्कुल.
क्योंकि हालत तो खराब हो जाती है देखते, लेकिन नेक्स्ट डे
हाँ, उस समय
ठीक हो
देखते हैं
जाता है.
पोस्ट ऑप आधे घंटे
हम
बाद
लोग सर
देखते हैं
नेक्स्ट डे ही
तो वो
देखते हैं
इफेक्ट
पेशेंट को.
लगता है.
सर ये कौन सा लेंस है बता दीजिए, यूज नहीं करना है.
नहीं एक तो ये एनस्फेरो था,
बता दिया सर.
हम लोग सर नेक्स्ट डे ही देखते
अप्पा का था, मैंने अभी कल ही मैंने
एक्सट्रीम
नोटिस किया.
विंटर में
सर ये फोटो खींच के डाल
करके जब
दीजिएगा.
एक्सट्रीम विंटर में, खास करके एक्सट्रीम विंटर में ये नोटिस होता है, और हर सीजन में 4-5 केसेस हमने नोटिस किया है.
सर फोटोग्राफ जरूर खींच लीजिएगा पोस्ट ऑफ की.
नहीं, डेफिनेटली.
मैं कह रही हूँ एक्सट्रीम विंटर में कैटरैक्ट सर्जरी नहीं करना है.
नहीं,
अरे मैडम पेट पे लात मारेंगे फिर.
ये रिकॉर्डिंग न्यूज़पेपर में रिलीज कर दी तो आपका सबका प्रैक्टिस खत्म हो जाएगा नॉर्थ में.
वो हर एक मरीज कहता है नेक्स्ट विंटर में कराएंगे.
You can stop the recording.
नहीं डॉक्टर साहब, विंटर में नहीं, ये मैंने समर में भी देखा है. नहीं, मैं हर सीजन में मिलता है.
कुछ वही टेम्परेचर का कुछ फर्क है,
और ये
अंदर जो बॉडी
डिपेंड भी नहीं कर रहे हैं.
सर हाइड्रोफोबिक में
रिक्वेस्ट है मैडम, जाने में कैटरेक्ट के बारे में बात मत करिएगा.
नहीं, मैं हंसी कर रही थी.
So I think that was
Yes, on a lighter note.
And this was a very good initiative.
interesting
Yes.
points which we all could cover. The
I will like to, Dr. Shashank sir, would you like to say something, few words?
नहीं डॉक्टर सालनी,
जी
ये
सर।
सेशन बहुत ही अच्छा था कैटरेक्ट पे, और आई थिंक इस तरीके के सेशन हर 2-3 वेबिनार के बाद एक बार कैटरेक्ट का होना ही चाहिए,
राइट
क्योंकि इसमें
सर।
पार्टिसिपेशन और जो लोगों का जो इंटरेस्ट है
जी
वो
सर।
काफी अच्छा रहा है, और इतने अच्छे अच्छे स्पीकर्स हैं आए थे, उनका जो शेयर किया, क्योंकि ये बहुत ही हर एक ऑप्थेल्मोलॉजिस्ट कम से कम कैटरेक्ट फेको से तो जुड़ा ही रहता है, और
राइट
इससे
सर।
और भी लोगों का इंटरेस्ट बढ़ेगा। आई थिंक अटेंडेंस और भी अच्छी होगी आगे। आई थिंक हर
जी सर।
2-3 वेबिनार के बाद इसको रखा जाए, जरूर कैटरेक्ट पे कुछ ना कुछ रखा जाए।
डेफिनेटली सर।
Very
एंड थैंक्स
interesting,
टू
very helpful.
डॉक्टर राममूर्ति, डॉक्टर
Yes. आप लोग को याद करना चाहिए कि हम ARC वेबिनार करते थे तो मंथली वंस चैलेंजिंग वीडियो सेशन करते थे, एंड
Yeah.
Yes, entire country, the kind of talent we have, it's a shame for us to even go abroad to learn. There is so many young surgeons and senior surgeons know.
Right.
All the 5 videos were amazing videos, very nice.
Thank you, ma'am.
Okay.
Thank you so much for being a part of this webinar.
Yeah,
And
thank you so much.
it was indeed a great learning. I will thank all the speakers. Dr. Chitra Ramamurthy, ma'am, we wish you all the best for the elections also. And of course, Dr. Gaurav Mishra, your 4D system is awesome. We
Yes.
all were awestruck to listen about it. And Dr. Shakya, I can't see him. Has he logged out? Dr.
He's there.
Shakya,
He's very much
There,
you
there.
were
I'm here.
amazing, wonderful video. And of course, Dr. Manish Mahindra and Dr. Prakash Gupta sir. So all the videos and all the techniques were so, actually, it was such a practical session that we all gained out of it.
Yeah.
So thank you so much, everyone. And of course, to our panel of judges, Dr. Vinita Singh ma'am, and you all inputs were really appreciable. And of course, Dr. Charu Mittal and Dr. Lakshmi, Dr. Anand Sharma sir, and I think Dr. DJ Pandey sir could not join because he was busy in some function. And I will also thank Dr. Pranav moderation, and we all are thankful to you, Dr. Pranay. And of course,
Thank you so much.
I'm very much thankful to Shashank sir, President, for all his guidance, supports, and this idea that we will go with video presentations of cataract surgery. And to Dr. Abhishek Chandra, who is such a dynamic secretary. And despite being so busy, he can actually spare time for these webinars. Thank you so much, Dr. Abhishek.
Thank you, Dr. Shalini. Thank you also for this great initiative, and best of luck for your AIUS elections also.
Yes.
Thank you.
डॉक्टर
Thank you so
प्रणव
much.
कहाँ पर हो बेटा?
Yes, sir.
तुमसे मुलाकात शायद
मैम,
मेरी हुई नहीं है.
अरे मैडम, ये
मैम,
डॉक्टर
प्रयागराज।
कमलजीत सिंह के बेटे हैं,
हैं?
डॉक्टर
डॉक्टर कमलजीत सिंह सर के बेटे
अच्छा अच्छा,
हैं
हाँ हाँ,
इलाहाबाद।
राइट, मुलाकात भी हुई है.
इलाहाबाद
सॉरी, हाँ,
जी, जी,
मिली
जी,
भी हूँ, हाँ.
मैडम, ये चित्रकूट के प्रोडक्ट हैं, चित्रकूट के प्रोडक्ट हैं सर।
नहीं, मैं मिली हूँ, मुझे याद आया. भूल जाते हैं भैया, हम लोग रिटायर हो गए.
So I will also thank Dr. Ashutosh जिन्होंने ज्वाइन कर रखा है from गोरखपुर. Sir, thank you so much. And Dr. Alok Ranjan अभी तक हैं, Dr. Ritu and everybody who joined, Dr. Sanjay Kakkar, everybody who joined this meeting and gave their precious time. And I would request everybody else to join even in larger number for these webinars and for these meetings.
And these webinars are also loaded on Facebook and YouTube on our UPSOS website. So if somebody wants to see later, they can see later also.
Definitely.
Thank you, ma'am.
Thank you, ma'am. Thank you.
Thank you.
Thank you, Dr. Shalini.
Thank you and good night.
Best of luck, Dr.
Great
Chitra
session.
and Shalini.
All the best.
Thank you, ma'am. Thank you, ma'am.
All the best. All candidates for AIS election.
Yes.
Thank you, sir. Thank you so much. Good
you
night,
and good
everyone.
night.
Merry Christmas to all.
Good night, ma'am.
Yes, Merry Christmas and
Yes,
Happy
Merry
New Year
Christmas.
also.
Merry Christmas.
Thank
Merry
you.
Christmas.
Merry Christmas and Happy New Year.
Thank you.
Happy New Year. Bye.